Hey there, health enthusiasts. Welcome back, and today we've got a topic: bronchiolitis. But before we embark, if you're new here, don't forget to hit that subscribe button and ring the notification bell, so you never miss out on our exciting medical content. Now, let's get started. Bronchiolitis is an acute inflammation of the bronchioles that is usually caused by a viral infection. It may occur in persons of any age, but severe symptoms are usually in young infants. Generally affects children less than 12 months of age. The younger the patient is, the more severe the infection. It has been noted that previous infection does not give complete immunity. Although reinfection is frequent, the severity of symptoms is lessened when there are substantial antibody titers from a previous infection. When it comes to etiological agents, the respiratory syncytial virus is the most prevalent. Additional agents consist of rhinovirus, human metapneumovirus, parainfluenza virus, adenovirus. The viruses are transferred from person to person through direct contact with nasal secretions, airborne droplets, and fomites. Adults who act as carriers may exhibit no symptoms at all or very minor symptoms. After a 2 to 5 day incubation period, the patient begins with coryzal symptoms. Later on, they can develop cough, fever, difficulty feeding, apneic episodes, and unsettledness or irritability. Severe cases can progress to respiratory distress. Infants younger than 1 month may present as hypothermic. Peak severity is usually at around day 2 to 3 from the onset of increased work of breathing, with resolution over 7 to 10 days, but the disease course may vary. A cough may persist for weeks after the disease. During examination, these features can be elicited. Fine rales, wheezes, or both upon auscultation. Tachypnea. Behavioral changes. Signs of increased work of breathing, such as the use of accessory muscles or chest retractions. Hypoxia. Other non-respiratory manifestations of RSV infections include otitis media, myocarditis, supraventricular and ventricular dysrhythmias, and the syndrome of inappropriate antidiuretic hormone secretion. Consider hospital admission for these children, even if presenting early in illness with mild symptoms. Chronic lung disease. Congenital heart disease. Chronic neurological conditions. Gestational age less than 37 weeks, or chronological age at presentation less than 10 weeks. Growth restriction. Indigenous ethnicity. Immunodeficiency. Exposure to cigarette smoke. Trisomy 21. It is a clinical diagnosis, based on typical history and examination findings. For most children with bronchiolitis, no investigations are required or recommended. Investigations, such as chest radiography, complete blood count, CBC, or blood culture, should only be undertaken when there is a deterioration or diagnostic uncertainty where we need to exclude other diagnoses, for example, bacterial pneumonia, sepsis, or congestive heart failure. Chest X-ray, CXR, is not indicated and may lead to unnecessary treatment with antibiotics. CXRs cannot discriminate between viral and bacterial infections and are poorly reproducible in this age group. Blood tests are not indicated, including blood gas and blood cultures. Virological testing, nasopharyngeal swab or aspirate, is not indicated in the management of individual children and should not be used to guide treatment. It is a self-limiting condition which usually requires no treatment or intervention. So management is directed towards symptomatic relief, maintenance of hydration, and oxygenation. Patients should be made as comfortable as possible, with minimal handling, held in a parent's arms or sitting in a position of comfort. Administer saline nose drops and perform nasal and oral suctioning initially. Administer oxygen, if necessary, to maintain an oxygen saturation higher than 90%. Infants with bronchiolitis and recurrent apnea or increased work of breathing with respiratory failure occasionally require mechanical ventilation. Bronchodilators should not be routinely used. Antibiotics should be used when proven coexistence of bacterial infection. Infants should not be exposed to passive smoking. Breastfeeding is recommended, according to RCH Guidelines management. Supplemental oxygen. The target saturation is 90%. Use minimum supplemental oxygen. Infants will have brief episodes of mild-moderate desaturations, less than 90%. Oxygen is not required for them. Nasal prong oxygen should only be instituted when oxygen saturations are persistently less than 90%. If oxygen saturations remain persistently less than 90% and there is no improvement in respiratory state despite 2 hours of low-flow oxygen, consider high-flow nasal prong. High-flow nasal prong is not recommended in children with SpO2 consistently greater than or equal to 90%. Trail off supplemental oxygen every 6 hours, but maintain SpO2 90. Once no longer requiring supplemental oxygen for 2 hours, discontinue oxygen saturation monitoring and observe 2 to 4 hourly. For hydration nutrition, continue oral feeds. If not, go for NG hydration. NG bolus feeding is safe and commenced at a 2/3 maintenance rate because of the potential for increased ADH secretion. NG feeding is not possible for hydration with isotonic fluid with added glucose is used. Do not administer or not indicated. Beta-2 agonists, corticosteroids in any form, adrenaline except in peri-arrest or arrest situations, nebulized hypertonic saline, antibiotics, azithromycin, antivirals, caffeine and chest physiotherapy. Deep nasal suction beyond the nasopharynx is not recommended. Superficial nasal suction may be considered in those with moderate disease to assist feeding. Nasal saline drops may be considered at the time of feeding. Considerations for discharge. Infants can be discharged when SpO2 greater than or equal to 90% and feeding is adequate. Infants 8 weeks of age are at increased risk of representation. Transfer to hospital in the home, HITH, on home oxygen, can be considered after a period of observation in selected infants as per local policies. Parents should be educated about the illness, the expected progression, and when and where to seek further advice. As we wrap up our discussion on bronchiolitis, I hope you found this information both informative and helpful. Stay tuned for more engaging and informative content on our channel. Don't forget to like this video, subscribe to our channel, and hit the notification bell so you never miss out on the latest updates. Stay safe, stay healthy, and stay informed.